እንዴት አመሻችሁ? Good evening, everybody. እንግዲህ I mean, the good thing about it, since most of you are Ethiopians, we can go ahead and talk in Amharic, which I believe most of us, almost all of us, speak and understand. I wish I know some other languages as well, Ethiopian language. Unfortunately, I don't. ምክንያቱም, you can reach out more people because language gives you the power, right? To reach out to more people. Anyway, the discussion is going to be, the lecture is going to be with English. So, I mean, like, it's not only Ethiopian medical students who would be benefiting out of this project, I believe. So some other people living somewhere else, if they get the opportunity, they can also listen and get something out of it. So, but the discussion is going to be more relevant to our institutions in Ethiopia, because I went to medical school in Ethiopia. I did most of my practice in Ethiopia, and I know the reality in ground. So whatever lecture discussion we do here, we try to make it as relevant as possible to the Ethiopian context, because the world is advancing, and most of the advances in medicine, clinical practice may not be applicable in our setup. But the good thing, through time, most of the technology is also coming to our institutions. So, whatever academic discussion, theoretical discussion we have, we will try to make it as relevant as possible to the Ethiopian context. So I will introduce myself in short. Maybe I have met most of you guys in different ways, either virtually through my videos or in person when I was in Addis a couple of months ago. Some of you might know me, but if you don't know me, my name is Fakada Selassie Henok. And I went to medical school in Black Lion a couple of years ago. And as soon as I finished medical school, I joined the institution as a faculty under the Department of Surgery. We were the very few lucky ones to get the opportunity to become an academic staff immediately after finishing medical school with 4 of my other friends. So we were the first to be recruited as an assistant lecturer at that time. So most people joined the institution as specialists, not as GPs at that time. So we were really lucky and fortunate to get that opportunity. Then I did my general surgery training, followed by cardiothoracic fellowship. Then I was an attending physician for a couple of years, and then I left to the US. I'm currently residing in the US, practicing in the US. So I did my internal medicine residency here. I'm done with it. So I'm practicing as an attending physician right now, board certified in internal medicine. So the main reason why we are conducting these lectures is because I feel passionate about teaching. And plus, I always ask myself, because I left my country at a very early age of my clinical practice. So back in my head, I always ask myself, how can I possibly contribute or continue contributing to my nation? And one of the ways is through engaging with the young medical students, junior faculty and all that, through education, through brainstorming and things like that. So one of the ways is giving lectures. So I feel fortunate because I specialize in 2 different disciplines, in medicine, internal medicine, and surgery. So that gives me a privilege to engage with everyone, at least in these 2 important disciplines in medicine. So I want to contribute, like I said. Probably you might have seen the introductory video, which we have released in Amharic. So the main purpose is to help you guys, assist you guys advance in your clinical practice. And we can potentially work together in the future, collaborate on many things. It could be research, it could be, a clinical practice, many things, so, and through lecture and all that. And I believe when you guys become full-fledged physicians, you will also contribute to your nation. So our first lecture would be some sort of a discussion with regards to the very common topics in general surgery, which are pertinent to your exams and your clinical practice at the same time. So I always say, even when I was back home, I always tell my students, the main reason why I invest so much time in teaching is not just to assist medical students excel in their exams. That is not the main purpose. It could be part of it, but the main purpose is to make you a better physician, to assist you in becoming a better physician so that you can help people, the poor and all that, our fellow human being, wherever it is, you know. So that is the main reason. So I want you to become an excellent clinicians, a very kind-hearted physicians who would be helping the poor, the needy, whoever is, looking for your assistance. Okay, so that is the main reason. So keep that in mind. And at the same time, of course, the discussion would help you do well in your exams. So last year, or I think it was in 2021, we had a similar discussion with a group of medical students who were taking their qualifying examination. So part one, I did it with them. So about 113 or 110 slides of this part of this presentation was discussed during that time. We have the recording. So myself and Brooke discussed that it may not be in everyone's interest to repeat that lecture because it's already there, and it was a very good discussion the way I see it. So you can always refer to that recording. So we will start from where we stopped. But in the future, if there is an interest to repeat that same lecture, if you want to do the lecture with you, if you want me to do the lecture with you, I'm referring to the part one, slides number 1 to 100 something. If you want to do that discussion again, we can do it. But just for the interest of time, we will be proceeding with part two, which is going to be a slide number 100 something. We will see it shortly. So we'll be discussing, and the discussion, I want it to be engaging. So I want you to participate. At least you can unmute yourself and then give answers, or you can just, send me a text when I raise questions. That way you can benefit a lot, because like I can simply record the video and release it to you guys, but it's meaningless. But when it is engaging to two-way communication, that way you can fix most of the information well. So just for the interest of time, I will dive into the actual presentation. And thank you, Brooke. And there are many other students and interns or new graduates who have really taken a lot of initiative to make this happen. So Brooke and his friends and EMSA Ethiopia, Addis Ababa branch, I would like to take this opportunity to thank them, because they really worked hard to organize this session for you guys. Okay, thank you so much. So this session will continue. So since I am the one who is directly engaged in this project for the time being, I will be conducting most of the lectures until we get volunteers, either foreigners or Ethiopians living in the diaspora, or even at home in Ethiopia. I'll try to recruit as many people as possible in different specialties to give you various lectures. Okay, so this is not going to be a one-time event. And if you show interest, if the turnout is good, and if most people think and believe they would benefit out of this project, then this project will become larger and larger, and it becomes more relevant to you guys. Okay, thank you for coming. I appreciate you guys. Let me try to share the slide. Just give me one moment. Okay, I think I cannot share it in full screen. Is there any way to share it in full screen, Brooke?
Yes, doctor. I think before you start sharing, you need to go to your slide and then slide share. Like, you have to turn on the slide share, and then you should reshare your screen. Otherwise, when you reshare, when you start your slide share, I don't think we can see the whole screen. Or you can also share your entire screen. That works.
What about this? I was trying to share the entire screen.
Okay.
And
that's the case. Then it works.
If that's the case,
it works. Yes, you can see.
Okay, it's good, right? So ከዚህ በላይ zoom ባይደረግም it's not a problem, right?
Yes, exactly.
All right, so yeah, so which part of the body is this one? So you see an X-ray of some part of our body, which is straightforward. It's the skull, right? So what is the pathology? Somebody is trying to help us understand what the pathology is. So is there anybody who wants to say something? So do you see anything here? Of course, at least we see a red arrow, and that arrow is indicating to something, pointing to something. So what's going on? Like I said, if you participate, you know, we benefit the most out of this. Yeah, somebody said, how can I see the, is it on the way? Do you see the chat? So I was trying to see the chat on the side so that I can.
We can only see your PowerPoint right now.
Oh, you can only see the
PowerPoint.
PowerPoint, so you don't see the chat box?
No, we don't.
Okay, excellent. So as far as it's not like, you know, interfering, that's good. So somebody is saying radiology shorts on chest trauma and abdomen. Oh, so that's you, right? So Brooke, so we will post the first picture. Okay, the first video. So that will be shared with you guys. So rest assured, don't worry about it. So it's a very detailed discussion until the 111th slide, as you can see. So we are on the 112th slide right now. So it's a skull fracture. So what kind of skull fracture is this one? So I mean, like, you know, one thing which I advise you is like, you know, be it in a clinical practice or like, you know, during exams, when somebody asks you what you see or what your diagnosis is, try to give like, you know, a full diagnosis at the get-go. Like, you know, if you say linear fracture of the skull, that's 100% point, you know. If you say fracture, yes, it is a fracture, but what kind of fracture, especially if there are multiple types, different types, you should somehow be very specific and to the point. That, you know, would put you in a better position. You can score well, you score well if that is the case. So this is a linear skull fracture. So yeah, it's related to trauma, right? So a skull wouldn't fracture without a trauma. So most probably this person has sustained head injury with linear skull fracture. So the diagnosis is head injury, most probable head injury with linear skull fracture. All right, so let's see. Okay. So what do you see here? So it's a clinical image. You see a patient, and there is, at least in the slide, there is something where a black arrow is pointing into somewhere. So what's going on here? And there is a lot of hair in this body part. At least I think this is the ear, I guess. So depressed skull fracture, excellent, Bethlehem. So there is a depressed skull fracture. Why do we think this is a depressed skull fracture? Because if you see, there is some depression, right? That's why it's called depressed. So the level of this bone and the level of this segment of the skull is at a different plane. So there is some depression in the skull. So this is a depressed skull fracture. Definitely, this is also related to trauma. So linear skull fracture, so when somebody sustains head injury, it comes to the casualty department emergency room. So if they tell you that they have sustained, for example, a fall down accident and they hit their head, if they have sustained a road traffic accident and their head is involved, then they might be bleeding from the head. There could be laceration on the skull. So some of the things you would suspect is like, you know, as simple scalp laceration could be the presenting complaint. It could be a simple linear fracture or depressed skull fracture. So when you see this much significant depressed skull fracture, what would be concerning to you? So you can do a simple X-ray, and the simple X-ray can confirm the presence of a depressed skull fracture. But if it is available, if you are in a center where everything is available, what kind of imaging would you want to do in this particular patient, and why? I'm sorry, like I told you, I have a very bad neck pain. Unfortunately, I have it today. So if you see me moving around, it's because of that. So just excuse me, okay? I have to massage my neck every now and then. Okay, so depressed skull fracture. So what kind of imaging do you want to do for this person? Yeah, CT scan, excellent non-contrast, and mainly because, like, the contrast would confuse you sometimes with bleeding. So the first imaging should be a non-contrast CT scan. Excellent answer. So if there is any associated bleeding, we'll talk about them shortly. So if there is any associated bleeding, you can diagnose. Simple skull X-ray wouldn't tell you whether there is intracranial bleeding or not. That is a shortcoming. You can at least diagnose a depressed skull fracture, but you cannot tell whether there is epidural hematoma, subdural hematoma, or like parenchymal contusion or intraparenchymal bleeding. You cannot really diagnose subarachnoid hemorrhage. You cannot really tell on a simple skull X-ray. So if there is access to CT, so you have to immediately do a CT scan without contrast. Excellent, Melad. This is the kind of answer I am expecting from you guys. I will give you 100% for your answer. Non-contrast CT scan. You can simply say CT scan, but don't say CT scan. And somebody would follow up that answer with another question, with contrast, without contrast. So don't allow your examiners, whoever is asking you, your instructors, to ask you more questions. So give them a full answer, then it is there, okay? And you get the full point, the full credit. All right, so you can, so this is, I think this is a CT scan, and you can see the bone window, right? So you can see the bone and you can see a clear depression, right? So there is a very significant depression, and there is also a disconnection between the plane of the bone. So there is a fracture here, there is a fracture here, there is a comminution or comminuted fracture down here. So this is a depressed skull fracture. And what do you think is going on here? Are you surprised if you see this? What is this part? Why is this elevated? So the rest of the skull doesn't have something swollen like this. It's straightforward. Can you guess what's going on? What is this? So it's it's a hematoma. Most probably it's a hematoma because, like we said, linear skull fracture, depressed skull fracture, basal skull fracture, all of them, they happen in the background of a trauma, right? There is a trauma causing this fracture. So if there is a trauma, definitely, if that impact or any trauma which is applied in the calvarium, if it results in this significant depressed skull fracture, that means it also damages the subcutaneous tissue. Obviously, there will be bleeding within the subcutaneous tissue. There will be hematoma. So there is hematoma, depressed skull fracture. Okay, so you can say, I say depressed skull fracture with a hematoma. It's a very violent force, right? It must be a high impact because the calvarium is not a thin bone, right? It's very strong bone. And the Almighty God, the way we are designed is fascinating, right? So the brain is a very delicate organ, and it's also a vital organ for us to function as a human being, right? So it's protected within this very hard shell or the calvarium. So it's not a thin bone, it's a very strong bone. So the impact must be very, very strong impact. So what do you see here? So this is a simple skull X-ray, most probably anterior-posteriorly taken. So what do you see? Do you see anything here? This is very common because, like, when I was an intern or a medical student, CT was not available right and left. So if somebody comes with a skull X-ray, or with a head injury, we tend to order a skull X-ray. So you order the skull X-ray, and then this X-ray comes to you. What do you see? What do you think is going on? What's your diagnosis? Especially in the countryside, you don't get access to a CT scan. So you should be able to interpret X-rays. Participate, guys. Type. Same patient? I don't think so. I don't know. I don't know these patients, by the way. This is an archive from a long time ago, so I don't remember exactly which X-ray belongs to which one. So you are a smart book. You want to guess the answer. depressed skull fracture on the left temporal region. So this is the right side of the patient, right? Because the patient is facing us, we are facing the patient. So rather it's the right side. So you see some depression here, right? So you can see some depression right here. It may be a little bit challenging to identify it, but there is a depressed skull fracture in this patient as well. So if you see this and if you have access, immediately try to do CT scan, like we have said earlier, because that gives you a better picture. So what is this diagnosis? What's happening? Which part of the body are we looking at? Tolo መልሱ, guys. If you participate faster, then we can cover a lot of the slides within a short time. Epidural hematoma, okay. So epidural, I mean, we will be discussing about how to differentiate between subdural hematoma and epidural hematoma on a CT scan. So they have their own typical characteristic. So that way you can, is there anybody who says something else? So everybody is saying epidural hematoma, it looks like. I have a different thinking. It's very adjacent to the parenchyma. It looks like to the very adjacent to the parenchyma of the brain, and there is some convexity here, right? So it's convex here, but it's not typically convex right here, right? So something is limiting its convexity. So what is that? So convex in one side, not really convex in the other side or in the side of the bone is not epidural hematoma, rather it is subdural hematoma, right? So it's subdural hematoma. Subdural hematoma by definition, sub means below or under. So subdural means under the dura or below the dura. So that's between the subdural, the dura mater and the arachnoid mater. That space is called the dural space. So subdural hematoma. All right. And you will understand it better when you see some other x-rays, I mean, some other CT scans. So I have a picture of epidural hematoma. So that would help you, identify it, make understand the difference between the two. So what about this one? So you can see blood here, right? So there is something is abnormal here. Right arrow, you can see this part is abnormal. So there is nothing similar. I mean, at least you can compare between the right side and the left side. There is nothing here, but here you see something whiter than hyperintense than the brain parenchyma, right? So if you go back here, so there is something here which is more dense radio density than the brain parenchyma. So we'll talk about classification of subdural hematoma. Subdural hematoma can be classified into acute, subacute, and chronic subdural hematoma in terms of the duration, right? So acute is immediate, subacute is up to how many weeks? Do you remember, guys? Remind me. Up to how many weeks is regarded as subacute? And beyond which point is classified as chronic? Anybody who remembers? Remind me. Anybody? Is it 1 week or 2 weeks? I think it's 2 weeks. I mean, I will verify. I don't know if you can verify, you can let us know. I think it's more than 2 weeks should be. Up to 2 weeks is subacute, and then more than 2 weeks is chronic, I guess. So can you verify, Brooke, in the meantime? You can Google it, whatever. So this timeline is very important because, and the other way you can tell is if it is very wide, very close to the bone density, right? It's not as dense as the bone, but it's more denser than the brain parenchyma. That tells you it's an acute process. So if you see this X-ray and this CT scan, then definitely this is an acute bleeding, and it's not a subacute one. But if you see the other one, which I showed you earlier, if you see this one, you know, it's getting closer to the brain parenchyma. It's not as intense, as dense as the previous one. Probably it's just, you know, subacute. And sometimes if it becomes darker, closer to the ventricles, not to the parenchyma, then it's going to be a chronic subdural hematoma. So people can't tell the duration of the trauma or the duration of the bleeding. Sometimes, you know, even with a very minute trivial trauma, people can develop subdural hematoma, especially elderly individuals with brain atrophy, and when there is a big space between the dura and the arachnoid matter. These bridging veins with even a small impact on the calvarium, they can rupture, and then they can give you a chronic subdural hematoma. And people wouldn't manifest right away because the bleeding is venous and it's going to be accumulating through a course of time. So the symptom is gradual, it's not an acute. They don't become symptomatic right away. So the weakness, the paralysis, the paraplegia, whatever, the aphasia, whatever it might be, it just develops over a course of time. So that's a chronic subdural hematoma, which we see in the elderly with in a setting of brain atrophy and all that. So in that case, the type of finding you see is like, you know, the bleeding, the collection is going to be hypodense compared to the brain parenchyma. So that way you can tell whether it's an acute process, subacute process, or a chronic process. Okay, that's an indirect one. And if you know that when that problem has happened, you can say acute, subacute, or chronic subdural hematoma. So this is the one of the classification of subdural hematoma. So you can see there is some convexity. It's pushing against the parenchyma, but the calvarium, so it's not biconvex. So this is a subdural hematoma for sure. So you can, this is a very good summary for you guys. What are the different spaces? Subdural, as I told you, sub means below, that's below the dura. So there is, you can see, if you magnify this, you can see the layers. So the dura mater has a periosteal layer which is attached to the bone, and it has a meningeal layer which is attached to the brain parenchyma or the meninges. So within that, I mean, anything below is subdural. Subdural, below the dura mater. So the second layer of the brain is arachnoid matter. You can see this layer here. So the space between the arachnoid matter, which is red here, and this one, the dura mater, is where you would get a subdural hematoma. And you can see these bridging veins. You can see a bridging vein which may rupture in the elderly, like I said. So they may be reporting a very trivial trauma. Okay, I remember hitting my head when I was trying to get out of my car. So as trivial as that one. So we always have an impact on our head many times, right? Trivial trauma, but we don't develop subdural hematoma because we don't have a brain atrophy. Young people do not have brain atrophy. There is no potential space. So these veins are not as such under stress or suspended at a low. But if there is a brain atrophy, what happens is, you know, this brain is atrophic and it's shrinking, and the space between the dura and the arachnoid matter is growing. And those bridging veins are like under a lot of stress. They are being stretched. So even a very simple impact would break them or rupture them. That's how people develop chronic subdural hematoma. Okay. But subdural hematoma, of course, can happen if somebody sustains trauma. Younger individuals with head injury, obviously, they may bleed into the the subdural space, and subdural hematoma happens. So the epidural space, EP means above or upon or above. So epidural means above the dura, between the calvarium and the dura mater. Okay, there is a potential space. So, and most of the time, epidural hematoma, the source is arterial bleeding. You should know, okay, subdural hematoma, most of the time the source is venous bleeding, and the epidural hematoma, most of the time the source is arterial bleeding. Okay, this is very important to understand. We'll talk about it, why that is relevant. Okay, so EP means above the dura. We are going to see that kind of bleeding shortly. So this is the subdural hematoma in the space between the dura mater and the arachnoid matter. So you can see very significant bleeding here, right? So this is an acute subdural hematoma. Still, it's pressing against the brain parenchyma. It's pushing the brain parenchyma. So the arachnoid matter is here and the dura mater is here. Between the two spaces, there is a subdural hematoma. So it's acute and it's going to be more dense. You see here, this is the outline of the brain matter or parenchyma, and the ventricles are being pushed. So, and if you see the midline here, it's shifting to the other side. So there are different criteria to when to evacuate a subdural hematoma. Okay, not all subdural hematomas might need to be evacuated because there should be yeah, up-to-date says excellent. So acute subdural hematoma, 1 to 2 days after onset, subacute, 3 to 14 days. Thank you so much. So between the third day to the 14 days after onset, and chronic is after 15 days. Excellent. Thank you so much, Brooke. You know, I read these things a long time ago, so it's also a good summary for me. So this is a very good classification. So between the third day up to the 14 days, when the CT scan comes, it's going to be isodense. This is the language you should use to describe it. Isodense. Isodense compared to the brain parenchyma. Acute subdural hematoma within the first 2 days, it's going to be hyperdense than compared to the brain parenchyma. And the chronic subdural hematoma is going to be hypodense compared to the brain parenchyma. Is going to be hypodense. And the density is going to be similar to that of probably the ventricles, not even close to the brain parenchyma. This is the density, you know, of the brain parenchyma. So it becomes more darker than this one. We call it hypodense. If it is similar to the brain parenchyma, we call it iso. And if it is more denser, we call it hyperdense. Okay, so based on X-ray, you can tell. Based on CT scan appearance, you can tell. Based on the duration, you can also classify subdural hematoma. Thank you, Brooke, again. Okay, so you see this. So how do you describe this? This is biconvex, right? So there is convexity here. There is also another convexity here. So it's following the outline of the inner lining, the inner shape of the skull. When we see at the skull from the inside, it's somehow concave, right? The shape is concave. So it follows that concavity. So the shape of the hematoma becomes convex, right? Convex. And there is also another convexity. You know the difference between concave and convex, right? So if you are focusing only on the bones, this is concave, right? This is concave. But if you are focusing on the shape of the hematoma, this one is going to be, when you look at it from the outside, it's going to be convex. So biconvex shape of a hematoma is very typical of epidural hematoma. And epidural hematoma is most of the time acute, and most of the time it's associated with trauma because the source of the bleeding is arterial bleeding. Okay, so biconvex. You see, it's biconvex. It's pushing because there is a lot of pressure build up because the bleeding is from the artery. It's an arterial source. There is going to be significant pressure building. So it pushes against the parenchyma of the brain. So this would be a convex shape for the hematoma, and it follows the outline of the calvarium. It gives it another convexity. So biconvex shape is very typical for epidural hematoma. And this classification is very important because one is arterial bleeding, the other one is venous. One is acute, the other one could be acute, could be subacute, could be chronic. So in terms of outcome, I am going to ask you a question. In terms of immediate outcome, immediate complication, which one is dangerous compared in comparison between epidural and subdural? Give it a try. Which one is dangerous? I told you what kind of bleeding they are, right? So immediately, which one is epidural, right? Epidural hematoma could be life-threatening, right? Unless you evacuate it immediately, unless you manage them immediately, it could be very fatal because it's an arterial source. It's associated with significant trauma to the calvarium. So the intracranial pressure is going to build up immediately. So the patient might develop increased intracranial pressure, eventually, you know, that would compromise, I mean, that would lead into herniation, brain herniation, and eventually death, right? So it could be fatal. So that's why we have to diagnose it immediately. So in best places where there is a very good, in a very best trauma centers, CT should be available in the emergency department. The patient comes, immediately suspect something, intracranial bleeding. You just, before you do anything, after you do the primary survey and all that, you can just, like, you know, subject the patient sent to CT scan. They do the CT scan immediately right there, and then while you are evaluating the patient, you diagnose it immediately. Then if you have to contact the neurosurgeon, you will contact the neurosurgeons right away. They have to evacuate this kind of hematoma immediately. So what type of surgical procedures do you know for management of epidural hematoma? How do you evacuate epidural hematoma? Bar hole, okay. Brook Zannaba, you are C2, you are in trouble. I'm joking. I love it. Give answers, because, like, you know, when you give answers, I would know what you are thinking. So when I know what you are thinking, then, you know, we can discuss more. Yeah, craniotomy, excellent. So you have to do craniotomy, because the reason why I say, Brooke, you are in trouble is because, like, you know, you said burr hole, and burr hole is a single hole, right? It's just one small hole. And you cannot completely evacuate epidural hematoma, acute epidural hematoma, with a burr hole. And reason being, it's an arterial bleeding, and the blood, after it goes into the epidural space, it has a tendency to clot. It clots, right? So you may not be able to completely evacuate the clot with a single burr hole. So that's going to be inadequate treatment. That's not the way you should treat it. You have to do craniotomy, and probably you guys might have had the experience. You might have had the procedures being done. So how do you do a burr hole? Have you ever seen? Did anybody see craniotomy being done? Yes or no? Those of you who have seen craniotomies being done. Did anybody see any craniotomy being done? You said you are from Blackline, so there are neurosurgeons in Blackline, and this procedure happens almost every night, as far as I know, because there is a lot of head trauma, brain injury, traumatic brain injury. Did anybody see craniotomy? Yes or no, guys? There are 27 participants, and if there is no single person who have seen a craniotomy, that's not a good sign. Not in person. Okay, maybe at least you might have seen some videos. That's also okay. I mean, if you don't have access to go to the operating theater, you can also watch some videos. I encourage you to see some videos on YouTube on how craniotomies are being done. So that gives you an idea. You know, otherwise it's going to be a fantasy world, right? So, I mean, surgery skills, they should be demonstrated. You cannot grasp the whole of it without seeing the actual procedure being done. So yeah, craniotomy, you do 4 different burr holes. You identify the place where you want to do your surgery, and then you do 4 different burr holes, and you connect those 4 different burr holes. If you are lucky, you are practicing in a good center, you may have, like, you know, a saw, an electric saw. So that makes your life easy. You do the drilling, you drill it, you make the hole, then you connect the holes with an electric saw. You are lucky in that case. But like when I was a surgical resident, I had the privilege of doing this procedure at that time. Neurosurgery subspecialty was just starting, and then we had some exposure. We had the privilege of doing these procedures even as a senior general surgery resident, and I had the privilege of doing this by myself. So what you do is, like, unfortunately, we use a jiggly saw. Have you ever seen a jiggly saw? It's just a wire with 2 handles at the end. Just Google jiggly saw and try to see how it looks like. So you pass a wire. There is some spatula not to damage the brain parenchyma. You pass it underneath between the 2 holes, and then you just, do you see me in action? I don't see myself. So when I am describing, you should be able to see me. Do you see me when I am just demonstrating? Do you see me, guys? Yes, so you see me. Okay, good. So with a jiggly saw, you just የጉልበት ስራ ነው. Like it needs some force, and then you cut through the bone, and then you connect all these 4 holes in 4 different corners in a form of rectangle or a square, and then you take out the part of the calvarium. So we call it craniotomy. Craniectomy is completely if you remove the calvarium. We call it craniotomy because tomy means making an opening. Ectomy means you are just excising something and throwing it away. So you are just making an opening in the calvarium. So that's why we call it craniotomy. You make an opening, then you evacuate the hematoma. After evacuation, then you place back the calvarium to a place where it belongs, okay? So that way you can evacuate the clot. The entire hematoma clot can be evacuated. You can irrigate with saline, and then eventually, once hemostasis is secured, you can put back the calvarium to its original place. So burr hole is a management for what? And the other thing, acute subdural hematoma, and probably subacute subdural hematomas might also require craniotomy, okay? Because there is a tendency for a clot formation, even with subdural hematoma if it is acute, and to a certain extent if it is subacute. So you may not be able to evacuate it completely with a single burr hole, okay? So burr hole is a typical management for what type of hematoma? I told you the answer. One thing is remaining, subdural hematoma, but what kind of subdural hematoma? I already told you, chronic subdural hematoma. Because chronic subdural hematoma, there is no clot already. The hematoma has hemolyzed. It's almost like, you know, watery, you know, there is no clot. It's under pressure. So when you make a hole in the calvarium, you make the burr hole, and then, like, you know, the dura would be tense. You will see the dura coming into the hole because there is a lot of pressure build up. So when you make a simple hole in the dura mater, it just gushes out. So I have seen that being done, and I have done it myself as well as a general surgery resident. We were fortunate in a way because at that time, you know, most subspecialties were not existing. So, I mean, as a general surgery resident, we had the exposure. Even as medical student, we had the exposure. We used to follow residents during duty hours. What it tells me is you guys are not following your surgical residents to the operating theater. So during your surgical rotations, whether you are interested in surgery or not, I think it's a good idea to go to the operating theater as much as possible. It was my happy place. It still is. So I used to go to the operating theater quite often as a medical student, okay? And that was really helpful because we do see most of the procedures being done. So when you study it, it becomes easy because you have seen it. So to describe it, to understand it, it becomes very, very easy. Okay, so my advice to you guys would be go to the operating theater as much as possible. Okay, it's not too late. You are just C1, so you still have C2. You have internship, so try to expose yourself to as many of the procedures as possible, whether you are going to become a surgeon or not. Okay. Alrighty. So which specialty are we entering? Bone, right? So orthopedic surgery. We'll be discussing some slides related to orthopedic surgery. Before I head out of the, yeah, I had another question. So before I forget, let me ask you. So in terms of long-term sequelae, if you, in comparison between trauma-related subdural hematoma and trauma-related epidural hematoma, which one do you think will have a long-term complication or sequelae in comparison? Trauma-related acute subdural and acute epidural. So immediate effect, immediate catastrophe is most of the time related to epidural hematoma, but it can also happen with subdural hematoma, by the way. If the subdural hematoma is very significant, if there is significant increase in the intracranial pressure, the same effect can happen, you know, herniation and days can happen even with a massive subdural hematoma. I'm not trying to underemphasize that one, okay? I'm not downplaying the impact. But in terms of long-term outcome, if you have to compare between epidural hematoma, subdural hematoma, which one will have a long-term sequelae? Subdural. And reason being, you know, to cause a fracture, it could be depressed skull fracture, and then significant parenchymal damage should happen if somebody develops subdural hematoma or intraparenchymal hemorrhage. So if somebody has trauma-related intraparenchymal hemorrhage, subdural hemorrhage, then that means there is an associated brain parenchymal injury, right? So most of the time, epidural injury could be a tear to the middle meningeal artery, and that's it. And then it bleeds, and it may kill you if you don't evacuate it right away. But there may not be associated brain parenchymal injury most of the time. But with a very significant intraparenchymal and subdural hematoma, there is a significant associated parenchymal injury, and that patient will have long-term sequelae or complications in relation to that subdural hematoma. Perfect, Mela. Thank you so much. So if you have any question, you can raise it before I go to orthopedics discussion in relation to head injuries, whatever. So traumatic brain injury, you should know about the management of traumatic brain injury. How do you manage a patient? What do you do for a patient with brain injury? I mean, somebody who has sustained head injury. You should know those things. Okay, read about it. Traumatic brain injury is a very interesting, fascinating topic. Okay, read about it. So how do you manage a patient with increased intracranial pressure? How do they manifest? You should know. Okay, you should know the manifestations of increased intracranial pressure, management, and things like that. I'm not going into that detail. Maybe we'll invite somebody from neurosurgery to talk to you about traumatic brain injury. So this is a short examination kind of discussion. That's why I'm not going to details. Or if you are interested in the future, we can talk about it. Why did we say slide 116 as subdural? Isn't it back convex? Okay, let me go back and let me try to see. And sometimes it could be a little bit challenging. You see this one, I mean, like, you know, if you see this side, it looks like straight, right, to me. So as such, there is no convexity, right? So to me, the dura mater is limiting. So the dura is just like a roof, right? Because the hematoma is under the roof. So the roof is straight like this. So it's not giving you a convex, typical convex shape like this. Whereas when you see it here, there is a little bit of convexity. So the way we describe it is crescent shape, you know, just like, you know, the moon, right? The moon is crescent shape, right? So something like that. When you come here, the same thing here. So there is no biconvexity compared to this one, where there is a very typical, where there is typical convexity here. So if it was a subdural hematoma, you would expect the line to be like this, right? So because the dura mater is here like this, and it's not allowing the hematoma to expand that way towards the calvarium. So it will be a crescent shape. There is convexity in one side, but it tends to be somehow straight in the other end. So crescent shape is a perfect description for subdural hematoma. So this is not a typical epidural hematoma, but you may prove me wrong. So when you go as a surgeon, you open it up and you find epidural hematoma. Oh, Fakada. So you said this could be subdural, but we found epidural hematoma. That's still possible. You know, it's not like, you know, 100% hard and fast rule, right? So there could be an overlap. It could be technically difficult for us to tell whether this is for sure subdural or epidural, but to a certain extent we can tell. You get it now, Bethlehem? I don't know if I have answered your question. So the dura is like a roof like this, and it looks like straight to me when I see the other slide. And most probably that's a subdural hematoma than epidural. All right. So the most important thing is it needs evacuation. So there are indications about subdural hematoma evacuation, epidural hematoma evacuation. Read those things because the neurosurgeons would ask you, when do you evacuate subdural hematoma? When do you evacuate epidural hematoma? Because like I said at the beginning, not every subdural or epidural hematoma requires surgical intervention. They may not need necessarily. So there is a criteria. Read about that criteria. Okay, so this session gives you an idea, and I point out things for further reading. So you guys are also supposed to do your homework, so you have to revise those concepts as well. Okay. So this is a bone, a bone of the pelvis, right? So you can see the pelvic bones. For revision, this is the ilium, the iliac crest. Okay, this is the sacrum, the vertebral column, so lumbar vertebra. So you have the pubic bone in yellow, you have the ischial bone here. Okay, and you have the symphysis pubis, and you have the femur, the acetabulum here, the neck of the femur. Okay, greater trochanter and lesser trochanter. Tubercle and the tubercle, pubic tubercle and all that. So these are different landmarks for revision. The reason why I brought it here is because, like, you know, when we talk about fractures of the pelvis, we should know the anatomic landmarks. That's why, okay? So the fracture involving the ischial bone, we say this is a ischial bone. So if there is fracture here, you call it superior rami pubic fracture. If there is a fracture here, you call it inferior ramus fracture. This is the acetabular fracture. The acetabulum is here, so acetabular fracture. Different fractures, sacral fracture, ischial, iliac fracture, and all that. They are not very common, but they can happen. So what do you see here? Normal, abnormal X-ray. Okay, so crossing suture lines isn't enough to differentiate epidural versus subdural, right? So I mean, like, you know, if there is if it crosses, then what does it mean? I mean, like, you know, the dura has attachment, right? So crossing the midline may not be a possibility in patients with epidural hematoma, whereas subdural hematoma, since it's accumulating within the dural space, then you may see, you know, crossing, but that can happen if it is a very significant trauma and the trauma is involving the midline. But yes, one way is just like, you know, if it is limited to one side, you can say, and it's if it is biconvex, most probably epidural above the dura, and the dura has attachment with the calvarium, so it may not allow the blood to cross into the contralateral side. Whereas in the subdural hematoma, that may happen. What do you see here? Any fracture, any abnormality, any pathology in this X-ray? Don't worry, by the way, when you try, you learn more, by the way. You try something, if you are right, you consolidate your knowledge. If you try it, but like you give a wrong answer, that's also fine, you know? So you shouldn't really, and we are not grading you here. We are learning here. So try to participate. So do you see anything in this X-ray, any pathology? Yes or no? Simple answer, yes or no. Then I will proceed, okay? No, so there is nothing, right? So it looks like every bone seems fine. We don't see any abnormality there, right? So it seems good. What about now? What about now? Right side rami fracture, so excellent. So you can see the superior rami, inferior rami fracture of the pubic bone, superior and inferior rami fracture. So this kind of fracture is unstable because, like, you know, the bone is completely separated, right? So it's completely separated. It's unstable type of fracture, so there could be associated, you know, injury to the different body parts. So this is superior and inferior rami fracture. Okay, is it a male or female? If I tell you, yeah, it's a male. Thank you. So what about this one? What's the pathology here? What's the pathology here? Symphysis, pubis. Yeah. How do you describe it? There is a very typical description of this kind of fracture, and you should say that at the get-go. Yeah, the fracture happens at the symphysis pubis, so it's completely like this, right? Wide open, right? So the two bones, can you see, they are completely detached. Open book. Thank you so much, Andu. So this is an open book fracture, you know, because like, you know, this is how the symphysis pubis was supposed to be. The two bones are connected here, right here, but it's completely detached. This is very unstable fracture. It requires surgical intervention. Okay. So how are these patients managed? How can you stabilize this kind of fracture? Have you ever seen a patient like this being managed in the orthopedics department? So how do you stabilize this kind of fracture? Open book fracture, how do you manage that? So this tells you a very significant trauma has happened to the pelvis. So there could be a lot of associated complications. There could be associated trauma to the urethra. There could be associated trauma to vascular structures, and patients might develop retroperitoneal hematoma, pelvic hematoma. A lot can happen. So this patient would you be surprised if I tell you this patient's blood pressure was like, you know, 60/40? Would you be surprised? You wouldn't, right? So there could be an associated significant intra-pelvic hematoma or bleeding. And the pelvic cavity is one of the spaces where there could be a very significant bleeding. And patients can present to you with hemorrhagic shock. Patient is not bleeding, but like to your surprise, the patient blood pressure is dropping and patient is hypotensive. And that's mainly because of, you know, concealed bleeding within the pelvic cavity. So pelvic splinting. So how do you splint the pelvis is my question. You are right. So you have to splint. The splinting means you have to make it stable. So how can you splint? For example, on the field, simplest thing you can do, what can you do to stabilize this fracture? On the field, if you are suspecting a very significant trauma to the pelvis, patient's blood pressure is dropping, and you are concerned about a potential bleeding hemorrhage within the pelvic cavity. So how can you stabilize, at least like until, you know, proper management can be done? How can you stabilize it? ስለማላያችሁ እኮ በቃ try. Draw carry around. Belt, you know, you should apply something, not exactly a belt, but like, you know, you can bring a bed sheet or whatever, blanket, whatever, and then you can tie it around the pelvic cavity in an attempt to stabilize it so that it doesn't move the way it wants. You know what I mean? Because if it continues, you know, behaving in any direction, and then, like I said, there will be more damage to various organs and structures, and there could also be life-threatening hemorrhage. So you can at least apply something around the pelvis, a bed sheet or whatever, and tie around in an attempt to stabilize it until somebody can take care of that fracture. So what other splinting mechanism do you know? People can apply a hip spica, right? Have you ever heard about hip spica? So it's going to be an assignment for you to read about hip spica. Or more definitely, you can also apply an external fixator. Have you ever seen a patient with a fixator, a metallic external fixator applied in the pelvis? Have you ever seen that? Yeah. So you can apply like, you know, external fixator as well. I'm trying to, if I can find an image, I will try to show you. So so something like this. I don't know if you can see this. Do you see this? So people can apply an external fixator around the hip to stabilize this. So you should know that. What kind of fracture is this one? Which part of the bone is affected? Very simple, straightforward. So yeah, femoral fracture, but what kind of fracture is it? Which part of the bone is affected? Shaft, yes, the proximal part of the shaft is also very close to this structure. What is this? What is this? This is a greater trochanter, adele? And this is a lesser trochanter. If a fracture happens here between the two trochanters, what do you call it? If a fracture is traversing this way, if it happens here, we call it intertrochanteric fracture, right? But something which just happens below the lesser trochanter, what do you call it? What do you call it? Something, a fracture happens close to the lesser, just below the lesser trochanter. What do you call it? Oh, no, this is not a femoral neck fracture. It's not. This is the neck of the femur. This is the head, right? This is the head of the femur. And this is the neck. This is the neck. This is a greater trochanter. This is a lesser trochanter. So femoral neck fracture happens here. The neck is fractured here. Head fracture happens here. And anything between the greater and lesser trochanter is intertrochanteric fracture. So these are different classifications of femoral fracture. Femoral neck fracture, intertrochanteric fracture, and sub. Excellent. Thank you, Andualam. This is sub, below the trochanter. So subtrochanteric fracture. It's a shaft fracture, but it's very close to the lesser trochanter. So people might talk about subtrochanteric fracture. Okay. So when you tell me, that's important because, like, you know, the management might be different. The way you manage neck fracture, head fracture, acetabular fracture, intertrochanteric fracture, femoral shaft fracture, subtrochanteric fracture, the management option might be different. So that's why you have to specifically tell us. So this is right subtrochanteric fracture or proximal shaft fracture. You can also say that. Okay. What about this one? By the way, what's a fracture? How do you define a fracture? Somebody, I need a volunteer who wants to speak up. Let me hear your voice. So somebody, a volunteer who wants to say, define a fracture for us. How do you define a fracture? A fracture is defined as, you don't talk? Anybody who wants to try. What's a fracture? How do you define a fracture? Volunteer. I will volunteer. Okay, Brooke, go ahead.
Discontinuity in the cortex of a bone.
Thank you. So it's just a break, right? Or a discontinuity in the cortex of the bone. So when the cortex is broken, or if there is a disconnect, then you define it as a fracture, right? So yeah, so always on an X-ray, we try to see if there is a break in the continuity of the cortex. Then if there is a break there, that means by definition, there is a fracture. So what kind of fracture is this one? What kind of fracture is this? I told you if a fracture happens is that, not exactly, I don't think so. Try to look into, it looks like a neck fracture. You see the neck is, this neck is fractured. You can see a segment here, a segment right there, and there is a crack. I see some crack here. So intertrochanteric fracture goes this way between the two trochanters, and it looks like, you know, the lesser trochanter is involved. So that way you may argue it is intertrochanteric, but it looks like a neck fracture. So when you see there is, like, you know, the neck has become shortened in this side compared to this side, right? So always compare. If you are confused, try to compare with the contralateral side. So this shows you somehow a comminuted fracture. What is a comminuted fracture, by the way? Comminuted fracture means There should be how many segments? More than two, two or more, right? So if there are like, you know, more than two segments, there are more than two segments, one segment, two segments, three segments, four segments, five segments. There is there is a comminuted fracture happening involving the greater trochanter, it looks like. So this is just an animation to demonstrate further. So you can see here, I think I'm repeating the same X-ray right here. So and what's going on here, the arrow indicates somewhere. So this is acetabulum, right? So there is a fracture here. When you see here, the cortex is intact. There is no discontinuity, but when you come here, there is a discontinuity. You can see some fragment here. There is some acetabular fracture, right? So so sometimes when there is a direct hit into the hip joint, you see a fracture in the acetabulum. Sometimes there could also be displacement, posterior displacement. So you see definitely acetabular fracture. So you see right acetabular fracture right here. What about here? The same thing, right? So in the left side, there is acetabular fracture. It looks like posterior displacement, right? So the head is coming displaced posteriorly. It looks like posterior displacement with left acetabular fracture. You can see there is a disconnect here. And you can also see superior rami and inferior rami pubic fracture. So this tells you this is a very severe injury, right? Because like it's not easy to fracture through the acetabulum, and multiple injuries has happened within the pelvic cavity. And that tells you maybe that the impact or the trauma was a very significant trauma. Fracturing the pelvic bone at multiple sites. What about this one? You can either speak up or text, whichever is easier. So what kind of fracture is this one? There is a break, right? There is a break, or it's a discontinuity, like Brooke said, in the cortex. This is the cortex of the bone. This is a cortex. So that's completely broken. That's why there is a transverse. Excellent. So the type is transverse, is a horizontal. So mid shaft. Excellent. Mid shaft. Why where? Tibulofibular. Wow. Tetana. Okay, it's a nice try, but it's not tibulofibular. There is an important landmark. What is this? That is a patella. So this is a femur. Okay, so this is a femoral shaft fracture. That's why I told you when somebody asks you the diagnosis, give a full answer. So when you say in terms of, instead of saying transverse fracture, I would be very happy if you say transverse mid-shaft femoral fracture. If you know the side, right or left side. How do you know the side? Number one, there would be a labeling in the X-ray. Right? They would label it for you by saying right, left. And number two, if you have the patient in front of you and you know the right leg is involved, then you would know that's the right leg for sure. Okay, so it's not tibulofibural. So landmark, patella, this is a femur. It's the largest bone in our body. And you see the tibia here, and you see at least the hair of the fibula here, right? So that way you know that you are dealing with femoral shaft fracture. So transverse femoral shaft fracture, mid shaft fracture. You can also say that. That would be an excellent description. So there are different types of fractures, classification of fracture. You should know about that. So excellently, you said asphalt, and you said transverse fracture. You are right. So this is a transverse fracture. The previous patient had a transverse fracture. Linear fracture can happen, though it's not very common. There could be a linear crack, and there could be oblique. Oblique is because of the shape, you know, because of the shape. Oblique, and it is non-displaced, you know, when you describe, make it, this one is displaced, right? So this is a transverse mid-shaft displaced femoral fracture. I will give you 100%. And whoever is asking you knows that you really understand the subject matter. So here, this is not displaced. This one is oblique. This is oblique, and at the same time, it's non-displaced. This one is oblique, but it is at the same time displaced. So you should say There is a significant difference between that in terms of management, in terms of outcome and everything. So oblique displaced fracture. This one is oblique non-displaced fracture. And this is a spiral. So a spiral fracture happens in what kind of mechanism of injury, by the way? A twist. A spiral fracture is a twist. When somebody twists the body part and fracture happens in that twist kind of mechanism of injury, you will find a spiral fracture. Oblique, the same way. And this one is a green stick. What is a green stick fracture? Green stick fracture, you should know. And in what age category do you expect a green stick fracture? What's a green stick fracture? Pediatrics, excellent, as far was saying. It's in pediatrics age group. It's just green stick means only one side of the cortex is affected and the other cortex is intact. Okay, so you can see that the continuity in the other side of the cortex is intact, but in one side there is a break in the cortex. It's not a complete fracture, or it's not a complete discontinuity in the cortex. So that qualifies it as a green stick fracture. Is common in children. So here you can see there is a complete discontinuity or break in the continuity of the cortex. And this one is a comminuted fracture. We talked about it. If there is more than or two fragments happening, it's a comminuted fracture. So what kind of injury would result in comminuted fracture? So if somebody tells you saying like, I was running and twisting and I sustained this trauma, would you believe that? When you take a history, somebody gives you the history of presentation and they tell you, oh, okay, I was trying to do something and I was like, turning around and then I sustained this fracture. Do you agree? Do you accept? No, it must be an assault, and it has to be a direct impact, right? So somebody hit by something, direct trauma, or a fall down accident with direct impact to the bone as a result of the fall accident, or somebody hitting the bone with a club or a metallic bar or something. So direct trauma, or with a blow with a stone or something. So direct blow, direct assault to the bone would result in a comminuted fracture. The bone would fragment into multiple small fragments. So what is the difference between oblique and spiral? Honestly speaking, they are almost the same. They seem the same, but at least the mechanism of injury in spiral injury is a twist, a twist in the body part resulting in a spiral injury. They look like the same, There is another classification which is not included here. Something how do I describe it? So can you add one other classification which is not here? Named after something which flies? Can you try? Solomon, can you try? A butterfly, excellent, Melad. Yeah, so excellent. There is also another one. Segmental, excellent. You guys are amazing. So Bethlehem, you say segmental. Segmental means there is a fracture here. There is another fracture at the second point. So there is a segment in between. You got my point? So there is let's say, forget this image. A fracture is here. Another fracture line is here. Then there is this segment, which is disconnected from the proximal and the distal segment. So that's why we call it segmental fracture. Excellent. And butterfly fracture is like somehow a comminuted kind of fracture. There is a crack. Forget this image. Forget this image. Forget this image. Let me describe it. So there will be a crack coming like this and going like this, coming like this and going like this. When you look at it, it looks like a butterfly. So a butterfly fracture, segmental fracture, linear fracture, transverse fracture, oblique fracture, spiral fracture, green stick fracture, comminuted fracture. These are the different types of fractures which can happen in our long bones. Okay, excellent. You guys are doing great. So what kind of fracture is this? Very simple and straightforward. Try, guys, you know it. I'm proud of you. What kind of fracture is this one? Okay, somebody has answered. Green stick, excellent. Green stick fracture. So why green stick? Because you see this cortex, the white line is the cortex, you see? This cortex is intact. There is no break in the cortex this side, but in this side, there is a crack here, right? So there is a disconnect here. So this is a green stick and it's buckled, right? So it's buckling. I mean, it's not broken. It has buckled, تطفل. It's just kind of buckled. It's not completely broken. So buckle fracture or green stick fracture. Okay, that's common in children. How do we know this is a child? You can see the gross plate here. You see the gross plate here? This is not a fracture, guys. Okay, this is a gross plate here. So this is a child. So we talked about it. Green stick fracture happens in a child. And you see the gross plate here. So you can say, okay, how do you know this is a child? And you would say, oh, I see the gross plate. Excellent. I will give you 100%. Go home with happiness. You see? Okay, beautiful. So you can see a crack here. It looks like, I don't know, maybe this is also another green stick fracture because I don't see any break here. Do you see any break here? We don't see any break here, but there is a crack here in one side. What about this one? Make me happy. Comminuted, excellent. Comminuted, which part of the body? You can see the head of the femur, right? Oh, I'm sorry. You can see the head of the femur here, the greater trochanter, lesser trochanter. If it happens here, we could have called it intertrochanter. If it was here, we could have called it neck fracture. It's just below, the fracture happens just below the lesser trochanter. So comminuted subtrochanteric fracture, excellent. Some comminuted subtrochanteric fracture of the femur. So what do you see here? So you guys are lucky. I'm not lucky, actually. Lucky or unlucky, I don't know. You decide for yourself. But I believe that you are unlucky because when I was in Addis during the qualifying exam, I saw that most of the examination happens on computer-based, which is a big disadvantage to you guys. And I don't believe it should be the way it is. But I think that modification was made because of COVID-19 to avoid, exposure to patients and to yourself. I believe so. But I mean, I see it as a downside. That's a personal opinion, mainly because, like, you guys would be studying this kind of slides and then you have never seen it on a patient, and who cares? You answer it during exam, but like, if I take you to a patient room, you don't know how it is done, you don't know what the purpose is, you haven't seen it applied to the patient. That's a big downside. So in the past, our short examinations and clinical examinations were patient-oriented, so we should be able to identify what's going on in the patient room or in the patient. So whether we like it or not, we try to see these things as much as possible. And the reason why we want to go to the OR was also to see it being practically done, then our practical exam becomes easier. Computer-based model, the biggest disadvantage of a computer-based exam is like nobody cares as far as you review the slides, and then nobody cares. So what's going on? Have you ever seen this on a patient, guys, in orthopedics department or in the emergency department? Have you ever seen this? What's going on? Yes, you have seen it. So what is this? So it's a traction system. What kind of traction system is this? Better and be specific all the time. You know it, but be specific. What kind of traction is this? Because there are at least two different types of tractions, the skin traction and skeletal traction. So is it a skin traction or a skeletal traction? This is, skeletal. No, as far as this is a skin traction. You see, you see this sponge applied here. That's to avoid a direct application of this plaster. You see this plaster being wrapped around the leg. So this plaster, we have never used this sponge. I mean, that's going to be very fancy. So you apply a plaster and you apply gauze or whatever to keep it. So the plaster, what we used to do, this is not a typical skin traction, because the way this sponge is applied, you apply a plaster longitudinally on the leg, which is going to be fixed to the skin. That's why it's called skin traction. And then at the end, you apply a piece of some hard material. Most of the time we use a cartoon, and we fold it and we make a hole on it, and then we wrap it with a plaster and attach it with a plaster, which is fixed to the skin. And then we hang something on that cartoon with a gauze or whatever, with a bandage rather, and then you hang a weight of a sand or a stone, whatever is available. So that qualifies it as a skin traction because the plaster is directly applied to a skin traction. It looks like a skin traction, and to me, and they have attached some weight right here, and they are trying to reduce. So they are trying to reduce a fracture. So one of the principle of management of a fracture is reduction, right? So you try to reduce it. After you reduce it, you try to maintain it in that position, in the reduced position, right? So they are trying to reduce, and the way they are trying to reduce it is by applying a force of gravity. They are hanging a weight, so on this weight, a force of gravity is applied. So there is a pull. So this distal segment is being pulled, and eventually it will, we hope that it will reduce the fracture and keep it in that reduced position. This is not ideal. A skin traction is not 100 fits. That's not the final measure which we are going to take, but it is a temporary measure until the orthopedic surgeon comes and evaluates the patient, or until the patient is safely transferred to an orthopedic center where there could be a definitive management. You can reduce and stabilize the fracture that way. Reduction and maintaining it in a reduced position is very important. Number one, you alleviate pain. When you reduce the fracture, the pain becomes less. Otherwise, a fracture is a very painful experience, very, very painful experience. So if you don't reduce it, what happens is those fracture segments are going to continuously injure the surrounding tissues, surrounding tissues, soft tissue, be it muscle or vasculature or nerve can be damaged. So reduction is very important. So as much as possible, try to reduce fracture as early as you can and keep it in that reduced position by splinting it. So this is one way of splinting. You reduce it and then you splint it, or keep it in that reduced position, so they're trying to do that here. So that alleviates pain. And the other advantage of reduction is it keeps the two fragments coming, connecting, touching to each other. So that facilitates the healing process. The healing happens when there is a connection between the fracture segments. If they are completely displaced like this, they are not attached to each other, they are not touching each other, then there is going to be no healing. So the reduction is very important. It promotes healing. Healing starts, it alleviates pain, it avoids further damage to the surrounding soft tissue, including muscle, vessel, nerve, and all that. Okay, so they are trying to stabilize the fracture by skin traction here. Whereas this one is a skeletal traction. A skeletal traction, because you can see a metallic pin introduced most probably through the tibia. You can see this is a thigh, this is a knee. So I believe it goes through the tibia, and you can see the metal here, and there is another metallic bar which is attached to here. And to this metallic bar, there will be a weight hanging like this. And then that also puts a continuous pressure, traction on the fracture segments that reduces it and it keeps it in place. So this is a skeletal traction. So if you are practicing in resource-limited setups like Ethiopia, where most places we don't have direct access for open reduction, internal fixation, at the event of the trauma, then this is one way of managing, femoral neck fracture, acetabular fracture, femoral shaft fracture. They are managed with a skeletal traction. So you keep the patient for a couple of months on a skeletal traction. And the downside of it is the patient has to stay on a bed for 2 months, 3 months until the healing process is completed. And that invites a lot of complications, including deep venous thrombosis. A patient will be deconditioned and all that, muscle atrophy because they stay on the bed. they will be debilitated, right? So, but if you are practicing in a center where there is access for orthopedic surgeons and where there is a technology, so they can do open reduction, internal fixation in different ways. There are different ways of managing femoral fracture, sign nail, intramedullary nailing, plating, different based on the type of fracture plus expertise and availability. So in that way, that should be the way. So because if you operate on a patient, fix the fracture, the patient can walk within few days and they can become functional, you know. But if you have to apply a skin traction, like I said, it's a temporary measure. At least the skin traction should be converted into skeletal traction to the minimum, because like you cannot keep the patient on a skin traction indefinitely. There is a lot of complication. It may slap the skin, and the amount of weight you can hang is also small compared to skeletal traction. Skeletal traction, you can apply bigger weight because the pressure is going to be applied over the bone, whereas on a skin traction, you cannot apply. I think if I remember correctly, you cannot hang more than 3 kilos, I guess, on a skin traction. You can correct me if I'm wrong. So this is a skeletal traction. Can I have more on how to differentiate whether a skeletal or a skin? The traction is, yeah, here it is. So that one, this one, like I told you, there is something applied on the skin. So they have applied this traction over the skin. The plaster is applied over the skin. Whereas this one, the pin is introduced into the bone. You see the bone, I mean, you don't see the bone, but you see the pin here, the metal, and they have applied this blunting, this red thing is to blunt the edge. Sometimes, if you have seen, okay, let me ask you a question. So I know whether you have been to the orthopedics wards or not. So what do they apply in our setup on the skeletal pin, especially on the medial aspect? If you have seen, what do they apply there? Have you ever seen something being put on the pin here? On the pin here, this red thing here is somehow, you know, plastic end over there. So there it's for a reason, because it's sharp. The metal is sharp because you drill it through the bone. It has to be, the end has to be sharp to go through the bone. So at the end of the day, something should be blunt, should be applied in one end. Why? And what do they use in our setup, if you have seen in orthopedics department? Gauze, yeah, gauze is applied around here. Sometimes they soak it with sodium and all that. No sodium, iodine, just to prevent infection, because one of the complications of a skeletal traction is pin tract infection, right? So through the pin, through the introduction side, there could be access to the bacteria, and then infection can happen. We call it pin tract infection. So they apply a gauze over there. Sometimes they cause it with an iodine and all that. But I'm talking about here. What do they apply? Have you ever seen anything? So yeah, they apply the antibiotic vial, right? So have you seen vial? You know vials, right? So powdery injections የሚቀመጡባቸው vials አሉ አይደለ? So somehow they apply those ones. And the reason being, you are trying to prevent what? Why do you apply that? I told you it's sharp. It has to be sharp to go through the bone, to be drilled through the bone. So what will happen if this is, let's say, the left leg, and you have a sharp metal here, and the patient's leg is here, the other leg? What will happen? Injury can happen, right? So you have to blunt it. So I believe this red plastic thing is applied here just to blunt the edge, blunt the edge, so that it doesn't damage to the cause damage to the contralateral leg. Okay, so you prevent soft tissue injury. So people can ask you, why is this vial applied here? So somehow you are blunting it. Okay. So what kind of fracture is this? At least let's finish orthopedics today. What kind of fracture is this? So anatomic landmark is very important, okay? So before you say something, try to see which part of the body is involved, okay? That's very important, because if you tell me this is humeral fracture, that's going to be a very, oh my God, I mean, your examiner wouldn't like it, right? So spiral, it looks like a spiral, or oblique, but it looks like a comminuted fracture involving tibial-femoral fracture. Excellent. So yeah, you are right. It's an oblique fracture. It could also be spiral fracture. It looks like here you can see the fracture line here. At the same time, when in the lateral view, you can see multiple segments. So it's comminuted as well. So it's a distal tibio-fibular fracture. How do we know that? This is the ankle joint, and this is the foot, and this is the fibula, and this is the tibia. Okay, you should identify your anatomic landmarks. That's very important. So this is a very comminuted fracture. So how many, as an intern, how many views do you order? For example, somebody sustains trauma to the leg, comes to you, you have to order an X-ray, or I will tell you, okay, order an X-ray, and I hang up on you. Okay, okay, do an X-ray and call me with the result. So what kind of X-ray do you order? Yeah, at least 2 views, right? So it has to be the rule of 2. Okay, in orthopedics, X-ray, there is a rule of 2. What does that mean? AP and lateral, excellent. 2 views. What else? Rule of 2. Another rule of 2. AP and lateral. Yeah, the view. So lateral AP and lateral. One is the view, and the other is limb. Yeah, so in pediatrics, for example, elbow fracture in the pediatrics age group might confuse you, and you may not be able to decide whether that is a growth plate or a fracture, an actual fracture. If you are confused, take an X-ray of the contralateral side for comparison. So in pediatrics age group, diagnosing fracture around the joints is challenging. So the contralateral limb should also be X-rayed. So 2 limbs, excellent. And 2 joints, excellent. 2 joints because, sometimes, especially, for example, forearm fracture, radioulnar fracture, sometimes there will be a fracture plus dislocation. It's not only in forearm, it's very common to have fracture of the bones, the radius and ulna, and at the same time there will be a dislocation of either the proximal or the distal joints. So you have to include 2 joints. So you have to include 2 joints at the same time to see if there is associated dislocation or not. And 2 views, 2 sides, and what else? 2 occasions, excellent. Solomon, why 2 occasions? Can you give me a very good example where taking X-rays at 2 different occasions would be relevant? Solomon, I'm asking you because tarsal fracture, yes, but common fracture in the hand, right? Which fracture in the hand? So the fracture, we say 2 occasions because if you take X-ray immediately after the trauma, it becomes normal. It's normal. There is nothing. Patient experiences, reports trauma, and at the same time experiences pain and tenderness on clinical exam, but the X-ray is normal. But if you take the X-ray after a week or 2 weeks, you may see the fracture line because healing happens. There is callus formation, new bone formation, and that kind of outlines the fracture line. So 2 occasions, that way it helps you to diagnose that fracture. The scaphoid fracture, excellent. So scaphoid fracture, typically, immediately following the trauma, the X-ray could be normal. But if you take the X-ray after 2 weeks or after 15 days or a week, then like I said, due to the callus formation, new bone formation, the fracture line would be outlined, and then you confirm your diagnosis. Clinically, you made the diagnosis based on the pain, the mechanism of injury, and the tenderness, a clinical finding, but X-ray might be negative. But in best centers, you do CT scan or MRI, then you can easily diagnose without waiting. Okay, so most of our discussion is oriented to our setup, the reality in ground. Most places we don't have MRI, most places we don't have CT scan, fancy stuff. So short of that, even X-ray can do a good job. So 2 occasions, 2 limbs, 2 views, 2 joints, 2 occasions. This is a rule of 2 in orthopedics, okay? You don't want to miss. You don't now. 2 joints are not included here. So what if there is a proximal fracture? What if there is a dislocation? What if something has happened upstream? So that's why you want to include the entire limb and see in its entirety. So what is happening right here? I don't know which part of the body it is, but like, you know, based on the appearance of the bone, it looks a big bone, big tubular bone. So most probably this is thigh, femoral fracture maybe. But so what kind of fracture is it? It's for sure displaced, right? We see only one segment, very unfortunate. So it's definitely a displaced fracture, number one. And number two, what's very important in this thing, it is an open fracture. It's open because there is a break in the skin. If there is a fracture, and if there is a break in the skin, and there is a connection between the skin or the external environment and that of the fracture line, then that qualifies it as open fracture. Okay, so a fracture can be classified in terms of the different types or X-ray appearances like we discussed earlier, or fracture can be classified as closed fracture versus open fracture. That is relevant because management really differs. So this is time sensitive. This fracture has to be managed immediately because there could be contamination. So that contamination has to be debrided. This wound has to be cleaned, washed adequately, copiously, please. Like, you know, if you are working in a district hospital and you find a patient with open fracture as significant as this one, please, please, please don't just say refer to Black Lion or St. Paul or whatever. Don't say that. Take your time, wash it, please, because you do a favor to that person. Wash, 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 wash. Wash it and then refer for further management. And the patient will thank you and would be you would be blessed for that. You will save that limb. Okay. So there is a classification, Gustilo-Anderson wound classification. Do you know that classification? I don't remember the specifics, but please go back and read Gustilo-Anderson wound classification for open fracture. That's very important. So from simple to complicated, dirty wound, okay? So the management really differs based on that classification. So I want you to revise that, or maybe in our future discussions, I will ask you, okay? Wherever I gave you an assignment, I will ask you, by the way, when you come back. So when we meet again. So this is an open fracture. So this shows you when a fracture heals, there are different things which can happen. So you can see a white line in between. There is some darkness here, and you see a white line there. We call it a sequestrum. It's a dead bone sitting in there. So this one, the hyperdense one, is a white one. The white one you see here, the white one you see here is an involucrum. It's a new bone formation. So a sequestrum is a dead bone. So how does this patient present to you? What does this indicate? So if you see a sequestrum, what's happening and what's the clinical manifestation? How do they present to you? A patient with sequestrum. If you see this X-ray, you should suspect something, right? So what do you suspect if you see a sequestrum on somebody's X-ray? Maybe you may meet one of the relatives outside of your OPD, and then they give you the X-ray, you see it, you don't have seen the patient yet, and then you see this one, and then what do you suspect? What's going on? And what is the presenting complaint of this patient, most probably? Dead bone sitting there. Chronic osteomyelitis, right? So somebody might have had a fracture. That fracture might have been healing, but the healing process for some reason might have been delayed. It could have been an open fracture, and the fracture is trying to heal, but there is a dead bone right there. So that dead bone, you know, hinders the healing process. There would be an infection, and patient would definitely present to you with a draining sinus, right? So pus is coming, pouring outside of their leg. So chronic osteomyelitis presents to you with a sequestrum in place. So if you want to cure this chronic osteomyelitis, you have to remove this sequestrum. So surgically, this dead bone has to be taken out, and if there is any dead tissue surrounding that, it has to be debrided, then the healing process can continue. Okay, so there are different complications. I didn't ask you complications of a fracture healing. What are the different complications of fracture? It could be displacement, and as a result of the displacement, there will be malunion. That means the union is not perfectly happening. Mal means, you know, abnormal healing. So malunion. So it's not united in a perfect way. So malunion can happen. Non-union can happen if it is completely separated. If they are not touching each other, healing never happens. So we call it non-union. Union might happen perfectly, but it may be delayed. It doesn't happen in that duration where we expect healing. We call it delayed healing, delayed union. So there could be delayed union, malunion, or non-union at all. So union is not happening at all. Sometimes there could be vascular injury associated with fracture. There could be muscle injury or other vital structure injury as a result of fracture. And the other complication is path embolism. You are right, especially if you have injury, fracture of a tubular, long tubular bones, there could be an acute complication in a form of path embolism. Excellent, excellent. There are many complications. Acute osteomyelitis can happen, especially if it's an open fracture. Chronic osteomyelitis can happen, especially in open fracture, especially if there is significant soiling or contamination of the fracture line. That's why, you know, debridement and washing is important. So this is a community fracture of upper humerus. It's already written. So you can see the thoracic cage here. You see the thoracic cage here. So you see the head of the humerus, and there is a fracture over here that's comminuted because there are multiple, at least more than 2 fragments, 1, 2, 3 fragments. So it's a comminuted fracture. It looks like a spiral or oblique as well when you see the pattern of the fracture as well. So it's a humeral fracture. So humeral fracture it can be associated with multiple, you know, injury to the neurovascular structure, which is running underneath. A very simple clavicular fracture. It's not that much consequential. It will be painful. It will be disfiguring, especially for ladies. Other than that, you know, clavicular fracture heals fast, and it may not be complicated with many things. So clavicular fracture management, most of the time, if you are in a best place, you know, they can do plating and screw. Plate and screw can be applied. So we call this ORIF, or open reduction internal fixation. So if you are not in a center where you can do this, you can also apply a simple sling, triangular sling. So if you see a simple clavicular fracture, you can just apply triangular sling, and the triangle, I mean, it takes a while and then it heals. The downside of it is, like, you know, since this clavicular fracture is most of the time unstable, it doesn't stay in one position, so the healing might be malunion, and it could be disfiguring. You see a bump of bone here sitting in the chest, and that could be a little bit disfiguring. So the best way to do it would be, you know, plate and a screw with open reduction internal fixation. So you see a fracture here. It looks like there is a joint being formed here, right? So there is a malunion, no union at all. You can see it looks like a pseudo joint formation is happening here. So have you seen a patient? I used to see a patient around Piazza who used to have, like, you know, a fracture here, and his limb is jumping like this, and that guy would never come back to Black Lion or somewhere else to get it fixed, because it's a source of income, unfortunately. Because, you know, there was a research done by Professor Brook and others in orthopedics department on most beggars around the city of Addis to see whether they would be interested to come for treatment or not. Most of them, I think that outcome, if I remember correctly, most of them, they don't want to come back for treatment, mainly because it's a source of income. So that guy, I remember him, he comes to taxis, the minibus taxis in the stations, and then he begs, and everybody freaks out because, like, you know, there is a pseudo joint formation in the middle of his arm, and his arm is swinging like this, and people are scared and they throw money to him. So that guy will never come to you. He doesn't need your treatment. He wants to eat. So pseudo articulation, pseudo joint formation is another complication of a non-healed fracture. It never becomes, it's not going to be painful. That's why he doesn't want to come, because it's new joint formation. It acts like a pseudo joint, a false joint is formed. It's never painful. So that's why they don't need their help, and rather they make it a source of income. You can see another fracture here. So displaced, it's angulated. When it is angulated like this, if it heals in this position, then it's malunion, and there is going to be deformity, limb shortening, and all that. So all that kind of stuff can happen. You can see fracture here. What kind of fracture is this? A pediatric age group is just a distal humeral fracture just above the ramus. What do you call it? Condyles, I'm sorry, above the condyles, medial condyle and lateral condyles. So supracondylar fracture. Supra means above, right? So these are the medial and lateral condyles. Just above the condyles, there is a fracture, distal humeral fracture. It's very common in children, and we call it supracondylar fracture. So you can see it here. It's just above the condyles, supracondylar humeral, distal humeral, supracondylar. We call it supracondylar fracture. Ulnar radius here. So this is where the supracondylar fracture happens. This is the area where just above the condyles, location of supracondylar fracture is very common in children. So the management is just like, elevate the limb like this. Maybe in the pediatrics casualty, I am sure you have seen patients who are hanging their arm like this, the skin traction is applied. You can see a skin traction is applied here, and then a weight is hanging here. So they are using this gravity, force of gravity to apply traction. So that way you reduce it and splint it at the same time. And in a matter of weeks, this fracture heals. I used to see a lot of kids with supracondylar fracture at the pediatrics department, emergency department, and some of them, they eventually get transferred to the wards until the fracture unites. There is a significant dislocation here. Elbow dislocation is common. And this one is radioulnar fracture. This is completely unstable. Remember, radioulnar fractures, if both bones are fractured, they are unstable. If one bone is affected, most of the time there will be an associated proximal or distal or proximal dislocation. That's for sure. Monteggia fracture, Galeazzi fracture happens because only one bone is fractured. So either the distal or the proximal joint is dislocated, because this is an unstable fracture by its nature. So if the force fractures only one of the bones, believe me, that energy is transmitted into either the proximal or the distal joint, and dislocation happens, or it breaks both bones. So both bones are broken. So conservative management is not going to be effective. So you have to do open reduction and internal fixation, or if, okay, that's very important. You should know that. That's the best way. Otherwise, temporary measure, you can apply POP. So you see plate has been applied for this fracture of the radius. The ulnar fracture is managed with plate and screws. Is open reduction and internal fixation. And this is another common fracture, Colles fracture. It's very common in postmenopausal women. Colles fracture happens in postmenopausal women. Typical patient age group is a woman in postmenopausal age due to osteoporosis. Mechanism of injuries: fall in outstretched hands like this. When they fall forward, they land with their hand like this, with their wrist extended, with the wrist extension. They land like this, and then the fracture happens. And what happens, what is typical, is the distal fracture segment is displaced to the dorsal displacement or posterior displacement, and then this elevation gives you an appearance like a dinner fork. So that's why they call it dinner fork deformity. You can see it better here. So the distal segment, this is a distal fracture segment, this is a proximal. So this distal segment is displaced posteriorly or dorsally to the dorsum, and that gives you an elevation here which looks like a dinner fork deformity. So that Colles fracture happens in postmenopausal women. There is another fracture called Colles-like fracture. If it happens in premenopausal women or in men, younger men, then you call it Colles type. It's not Colles, because Colles fracture is typically seen in postmenopausal women. There is another, this is also another picture, I think. So all this demonstrates how the distal segment is displaced posteriorly and giving you this bump here in the dorsal aspect. You see this bump, that's why they call it dinner fork deformity. Okay, it looks like a dinner fork. That's collas fracture. You see it better here. Collas fracture, you see, dinner fork deformity. The distal segment is displaced dorsally. It's a distal radial fracture. Okay, so they have, it looks like this, a dinner fork deformity. So it's very common. I have seen a lot of dinner fork deformities when I was resident, and this is how they fall, and this is how the distal segment gets displaced to the dorsal aspect. All right, dorsal tilt, shifts and tilt with mechanism of injury with extension of the wrist. Okay, guys, I will finish orthopedics in few slides, and then maybe we call it a day because we have stayed a long time. So this is how you reduce it. So you can read through these texts. So an assistant help you. They apply traction proximally. So the operator or the surgeon, whoever is trying to reduce it, can hold with their thumb, applying a push on the distal segment, trying to move it forward to the volar aspect. And then at the same time, you allow more knee extension. Then you disimpact it. After disimpaction, you try to orient it. You have to see it being done. And then you apply a Colles cast, a POP like this. Try to maintain it in that position, and then it heals within a couple of weeks. Okay, it's very common in elderly individuals. A Smith fracture is opposite. A Smith fracture happens when somebody lands on their hand like this. It's very odd. Okay, so our instinct tells us to land like this, right? Not land like this. So if you land like that with a wrist flexion, then you will have another kind of fracture called a Smith fracture. What happens in a Smith fracture is the distal segment will be displaced to the volar aspect, to the anterior aspect, not posteriorly. That's the complete opposite of Colles fracture, which is extremely rare because we don't really fall down and land like this. We land like this. Okay. Alrighty. So yeah, you can read through that text as well, so you can see these phalangeal fractures. Okay, they are simple fractures. You can apply some metallic pin to stabilize them, or if you don't have this expertise or you cannot apply this intervention, you can also sometimes splint the two fingers together. We call it buddy splinting. Buddy, you are trying to make the neighboring finger as a buddy or friend. Buddy splinting can apply. You can just do that, or you can apply a spatula and try to stabilize that fracture for a couple of weeks and it heals. But the best thing is to pin it if you have best orthopedic center. Bimalleolar fracture, here is a lateral malleoli, medial malleoli, lateral malleolar fracture. This is bimalleolar fracture, is very common in ankle injury. Here you have patellar fracture. It's completely, because a very strong muscle is attached here, they will be completely separated. So this requires internal open reduction and internal fixation. That's a must. So you apply wiring. So I have seen wires being applied in a form of figure of 8. You see this, and you apply the wire in a form of a figure of 8 to keep the patella together. So open reduction, internal fixation is a possibility. For bimalleolar fracture, you can apply just a screw through the malleoli, fix it that way, or you can also apply plate and screws if it is more proximal. Plate screws or a screw can be applied for bimalleolar fracture. A bimalleolar fracture, another one, this is just metatarsal bone fracture. They are stable, so just you can apply posterior gutter or short leg cast, and then it heals. Or you can apply a boot because it's just a kind of stable kind of fracture. All right, so this is a POP. I am sure you guys have seen POPs. So POP is our friend because in most centers in our country, especially in the countryside, even in the main cities, we don't have access for open reduction, internal fixation, right and left. So our friend is POP. And now I am sure you have seen a POP being applied. So this is a long leg cast. People may ask you, what is this? We call it long leg because it includes the leg and it's up to mid-thigh. So if people ask you where is the problem, most probably it's a tibiofibular fracture around here. Both joints, what joint proximal and joint distal, are included in this cast so that you stabilize the fracture. Okay, so long leg cast can be applied for patients with tubulofibular fracture. If the fracture is on the foot, you should apply only a short leg cast. You don't have to apply up to here, and you have to free the knee joint. Okay, So this is called the cylindrical cast. It's called cylindrical because the shape is cylindrical, and it's different from the long leg cast because it doesn't include the foot, right? It's not coming up to the foot. It's just like, you know, somewhere above the ankle joint. So typically cylindrical cast is applied for problems in the knee, and particularly patients with patellar fracture can be treated with cylindrical cast. Okay. So this is upper extremity injury. This is a use lab, most probably. It's a use lab. Use lab is applied like this. You start from here, it comes like this, and it goes like this. Lateral and medial aspect of the arm. And that is typically done for patients with humeral fracture. All these fractures, the best way to manage a fracture is open reduction internal fixation. There is no question about it. For resource limited setups like that of ours, since we don't have access to orthopedic surgery and all that, we can manage them with POP. The first thing you should apply once somebody has sustained fracture is a posterior gutter, okay? A posterior gutter, especially in the acute setup, apply a posterior gutter. The reason we apply a posterior gutter is because we want to avoid, you know, further swelling. If you apply, you know, something circular, if you apply a circular cast like the long leg cast you have seen, or the cylindrical cast you have seen, the main problem would be immediately following trauma. There is going to be a lot of inflammation going on. There will be swelling, right? So that swelling, if you have applied a circular cast, then you are going to compromise the blood supply to this limb, and you are going to damage the limb. Okay, a compartment syndrome might happen. So immediately following trauma, all the time apply posterior gutter. You are applying the cast or the POP only on the posterior aspect. The rest would be strengthened by bandage, and they are applying this to protect the skin because this is rough. Okay, they are trying to protect the skin. And in our setup, most of the time we apply a cotton. Cotton is applied before you apply a posterior gutter or whatever kind of cast. Okay, this protects from the injury of the soft tissue. Okay, this is a thumb spica. They call it a thumb spica. They are immobilizing the wrist joint and also the thumb. So this can be used to immobilize the wrist, and it also immobilizes the carpometacarpal and metacarpophalangeal joints of the thumb. So in a scaphoid fracture and all that, you can apply a thumb spica. Okay, this is what is meant by a thumb spica. The thumb is immobilized. I never knew we had a lot of orthopedics. So this is a posterior gutter. I know that this is a posterior gutter because I see the cast here and I see one end of the cast here, another end of the cast. This way we don't see anything anteriorly, and because it's a posteriorly applied cast, posterior gutter. Okay, posterior gutter is applied immediately after the trauma to buy sometimes. It reduces the fracture, it keeps it in place, it splinters it. Then once the patient is out of the danger of having more pronounced swelling and all that, then you can apply either a long leg cast or anything, okay? The danger of compartment syndrome would be less. And here is the circular cast applied, and at the same time, you can see somebody is trying to open a window here, and you can see blood staying here. So the reason why they are making an opening here or a window is because a patient had an open fracture. You see the open fracture? So this is what is meant by a window. You apply a circular cast, but at the same time, after you finish applying it, you can create a window. So that gives you access to the wound so that you can continuously deliver wound care. Once you finish the wound care, you can put that piece of cast you have removed. Okay, so this is what is meant by a window. So an open fracture can be treated with external fixator without applying a cast. That external fixator will stabilize it, reduce it, and at the same time gives you access to the wound for wound care. If you don't have an external fixator, if you are not expert in applying an external fixator, or you don't have an external fixator in your center, you can apply a POP, a circular cast, to reduce the fracture, keep it in place, and at the same time you create a window and get an access to continue care caring the wound. That avoids osteomyelitis in a form of acute, be it chronic osteomyelitis. You got it? So this is a window. You can see this flap. So it can be applied after you clean the wound, okay? And this is how you remove the cast. So once the cast has been there for a couple of months, the fracture heals, you are happy about the healing and you decide to remove the cast, then this is how you use an electric saw to cut through the cast and remove it, okay? This is what is meant by external fixator. This is a very bad, maybe like, you know, an advanced Bustulo Anderson class open fracture. So you can see the fracture is kept open for continuous irrigation and debridement and all that in an attempt to prevent chronic osteomyelitis wound infection from happening. And the external fixator, you can see the external fixator here. You see the external fixator that stabilizes the fracture in place. It keeps it in place so the fracture is not allowed to move. And at the same time, you are not applying this posterior, full cast, and you still have access for wound care. All right. That's it. I think, like, you know, the next would be, some GI. And I think we have covered a lot of slides today. It has been a long time. We took almost 2 hours, I guess. So I believe that you have learned something out of it. I hope so. So what do you think, guys? So thank you so much, Brooke. There is a lot to learn, guys. So there is a lot to learn. Just be ready, get engaged all the time. There is a lot to learn. And in medicine, to become a better physicians, you have to expose yourself to many things. You know, you cannot stay in the library and be an amazing physician. That's not the way. You should be very close to the patient. So the patients are the best textbooks, believe me. So the more you see, the more you know, the more you become efficient, the more you become an excellent clinician, rounded. So whether you are going to be a gynecologist, a pediatrician, whatever, it doesn't hurt having a knowledge about trauma. You may be the only person to help this person, for example. So at least you can wash. If you have seen, if you have been listening to me, I told you, before you refer this patient, a patient with a fracture like this, with open ugly wound like this, before you send the patient to black line or something, take some time and wash it, please. That's it, because it's time sensitive. So wash and reduce, apply posterior gutter, and send the patient. Give analgesia, send the patient for referral. Even if that patient doesn't get access to orthopedic surgeon immediately, at least you are saving that person some time, okay? All right. Excellent. So we'll continue doing this. So this is surgery, whatever you want to call it. So we would also be having similar sessions in internal medicine, gynecology, obstetrics. We'll try to identify individuals who are happy to volunteer and be part of this noble cause. So until such a time, until we find people who can participate and run similar sessions, I'll continue doing what I'm doing right now. So there is a lot remaining. I think the maximum number of slides in this presentation is about 305. So more than 120 or whatever slides are remaining. So when you guys let me know what time would work for you, I'll try to make an arrangement and we'll have another session and we will finish this instrument and short discussion, and then we advance to some other relevant topics to you guys, okay? And what I encourage you guys is, like, you know, your interest to participate to such sessions shouldn't be high only during the exam seasons. It has to be there all the time, okay? Participate. When you have the opportunity, participate and participate and participate. And then if you participate ahead of the exam period, then when the exam approaches, you will be the happiest person, you will be the most relaxed person, you wouldn't be panicking, and you learn a lot, okay? You learn a lot. When exam is not associated. Otherwise, like, you know, even if I talk a lot of stuff during exam season, you are anxious, you are like, you know, new knowledge might come towards you and then you will be frustrated. I don't know this. So that will be frustrating to you, okay? So if we do it earlier than the exam periods, the better you will benefit, okay? Thank you so much. Brooke, do you have anything to say? And I'll let you go.
No, thank you. Thank you, Bilam. Thank you, Bilam, Doctor. Thank you for your time. This was really amazing. And I hope
great.
like የሚቀጥለውንም በዚሁ አይነት ፋሽን ብናደርገው because I really like ያደረግነው በጣም አሪፍ ነበር.
Excellent. I believe so. I mean, when it is interactive, I mean, like if I was presenting it, if I was recording this video, believe me, all these things which I have been discussing wouldn't come out of me.
True, that's
but
true.
like, you know, when I am asking questions, when I know that somebody is listening to me, when you guys are engaged, especially when you guys are actively engaged, then you will make me talk more and more and more and more. That's the way you benefit. So I would have finished the entire 300 slides within 1 hour if I was speaking to myself, you know what I mean? Because it's easy because I'm describing what I see, whatever. But if somebody is engaging with me, asking questions, giving answers, and then I would elaborate and more, even though it takes a longer time, you benefit a lot. Okay, so you can, for example, you can see only 30 minutes video, for example, only the orthopedics part, only the GI part, only the head, whatever, the neurology part. You can do that, you know what I mean? Even though it is a 2-hour session, when you revise it, you can revise only 10 minutes on 30 minutes based on your demand. That way you benefit a lot. So I think if we conduct every lecture like this with engagement from you guys, that would be very helpful. And what I encourage you, I mean, God willing, if I succeed to involve other people, even like, you know, foreigners, whatever, to give you lectures, whatever in the future, you have to engage because like, you know, here the culture is different. You cannot keep quiet like this. Okay, don't be mute, participate. Okay, speak up, communicate, engage, because like, you know, medicine requires communication. You have to be very good communicators to be good, very good, excellent, amazing physicians. You cannot keep your knowledge to yourself. Okay, you have to learn how to express yourself. So that's also a skill, so you should develop that. Okay, and most of you guys are aspiring to be an international physicians, right? So you cannot be mute and then be excel in the international world. No, you can't. That cannot happen. So one piece of advice for you guys is when I ask questions, engage, either in a text or speak up, speak loud, explain, you know, use it as a practice venue. Okay, that's the only feedback I have. So Brooke, just you know, once you download the recording, send it to me. I'll try to share it on my platform as well, and we'll continue doing what we do. Okay. ከእግዚአብሔር ጋር እና I wish you all the best, those of you guys who are approaching to your exam. Study hard, don't panic, be yourself, and I know that you guys are amazing. You will do well. Okay. All right, good night guys.
Okay, good day, Doctor. Thank you.
All right. Nice meeting you guys. ከዚህ በፊት ያልተገናኘን ልጆች እንዳላችሁ እንኳን በሰላም ተገናኘን። Bye.
Ciao.
Ciao Brooke. Bye. Thank you so much.